Frankly, for inviting me here. I was called in the 90s as a dinosaur because I believe in open. I evolved into a rock lizard. Is it moving? I have nothing to disclose. This is the acute dissection. Those who use the endovascular treatment has to see the dissection. It's really a wet tissue paper. And you put this as stent. I don't know how to stay open. This is the chronic, this is the acute dissection type B, and this is the intraoperative photo, and this is the operation for that. As you know, loaded into a dissection was A, B, DeBakey 1, 2, 3, and now I think the best is this is SVS, STS classification. I do believe all aortic dissection need lifelong follow-up. And this is a patient who, they collected 66 patients and no treatment for surgical treatment for acute TAP aortic dissection. Look, after the 7 days, almost 90% of them are dead. So if you look at the International Registry of Acute Aortic Dissection, the surgical treatment for acute type A is superior to medical treatment. In regard to type B, you'll see that medical therapy as good as the, better than surgical therapy, maybe TVAR will work there. And when we looked at our experience in ascending aorta repair and what happened with their long-term survival, we found that it's related to the renal dysfunction and COPD. So that's, keep it in your mind, what's a high risk. And the risk factor for outcome of, in our experience, type B aortic dissection is rupture, COPD, and renal, a problem. In our experience with acute type B aortic dissection, the gold standard is cardiopulmonary bypass, profound hypothermia, circulatory arrest, and open distal anastomosis as described by the late Dr. Cooley. With regard to acute type B aortic treatment, I think the first line of treatment and complicated is medical therapy. For complicated, I think our reserve, the open for heritable thoracic aortic disease, Marfan, Lewy-D syndrome, Ehlers-Danlos, and the rest, and rupture because it's quick to go and fix the problem. With regard to the chronic aortic disease, for dissection, I think the ascending aorta, personally, I think is a gold standard is the open. Extensive aortic aneurysm with elephant trunk is the open. For descending thoracic aortic aneurysm, unthoraco-abdominal, I believe the extent C, where the risk of paraplegia in our hand is less than 1%, mean extent from left subclavian to T12. All thoraco-abdominal aortic aneurysm, people with aortoesophageal fistula, aortobronchial fistula, and rupture. This is a patient who developed acute dissection requiring repair of his ascending aorta. He developed aortocutaneous fistula. Every time he got involved with his girlfriend, he would spew blood on her chest. So we fixed him like this, and he lived about 9 years, didn't die from rupture. This is a patient went for checkup, and this is what they discovered, and this is how we repaired it. This is a patient who the upper descending was removed, but the rest of the aorta in open got big, and so we repaired the rest of the aorta. This is a patient who was presented with Marfan, symptomatic thoraco-abdominal aortic aneurysm, and I think an open repair is better. This is the same patient who has ascending aorta and ours get big, and we had to do a proximal repair. And this is a patient who presented with rupture descending thoracic dissection. They put a stent in July. In September, start vomiting blood, and the X-ray shows you, the CAT scan, that there is air and communication with the esophagus. And this is when we remove the stent. And this is the clot, the connection between the esophagus of the aorta. And I don't think there is any stent kind of plug this. This is a hole in the aorta attached to the esophagus. And this is the best place for the stent, is a emesis basin. And then we repaired it by thoracic repair, and we repaired the esophagus. And this is his esophagogram. And I told her, what do you want? She wanted to have a grape juice. And after 4 months, she didn't eat, and we celebrated her grape. And this is a patient who had minimally invasive mitral valve. They did the ascending, and then this aneurysm as big, and I don't think there is any debranching here, and we replace it with a descending thoracic aortic, and the patient did fine. This is another patient, even when you put a descending stent, and you have to follow them for life because the rest of the aorta got big, and this is how we repaired it, where we sutured the graft. And with that, I think there is a place for open surgery.